had some wonderful students moderators, and then we've started with Attorney Fred Gray on Monday. We've responded to by Dr. Ruben Warren, and that was a wonderful experience, especially, again, all that we do, there's nothing more priority than doing it for our students. And when I say our students, I don't mean the Tuskegee students or just the bioethics honor students, but students all across the country and the world. We could imagine now doing it Zoom. It's interesting. Last when I first got to Tuskegee, we started having conversations about how to expand it to up across the world. We didn't know it would take a coronavirus to put us in a position where we'd have to develop the genius, because creativity is the mother of necessity is the mother of invention. Necessity is the mother of creativity. So because of the lack of because of the presence of COVID, that allows us to reach people, our colleagues in Africa, South Africa, Rome, all around the world. So that's just a beautiful thing. Not only because of the Zoom, but this presentation is being recorded. And then after we edit it, we'll put it on Facebook as well as YouTube. So therefore, there will be a continuous record for people to participate in here and put it in their classrooms and have these wonderful conversations. So we are thankful to God for that. So the first part is that we really appreciate our students who are serving as moderators, and then we appreciate our presenters. The first essay was Attorney Fred Gray and Dr. Ruben Warren. Then we had Dr. Riggins Earl to present on voting rights, equity, and equality, and responded to was by Dr. Chom. That was just a brilliant conversation. And then yesterday we had Attorney Monica Beamer and Attorney Charlene Bryant. So if you didn't see them when it comes out in YouTube, you go back and watch, and you will have quite a time because they are special. I mean, they have a whole lot of energy and focus and passion and determination. And then we had, after they presented, we had Attorney Latasha McCrary, who presented and was responded to by one of the persons who was with us last year, Dr. Sowande Mustakim, who wrote a book called Slavery by Sea. If you have not read that book, you may want to pick it up. And it raised questions about the absence of the presence of women in the Middle Passage. It seems like only men were in the Middle Passage, but what about the women? So her research is a historian tenured at St. Louis University in Washington. So that was a beautiful presentation. And then after she spoke, then Dr. Randall Bailey, who is, you see behind you there, eating an apple or a banana or a cookie, Dr. Randall Bailey presented on ethics and vulnerability, truth and faith. And then I responded to Dr. Bailey. And I think where we certainly did agree is the hermeneutical struggle in trying to figure out how to speak about God, who in our best day, all we have is metaphors. Now, having gone through that today, we're looking at ethics and vulnerability, or women and children, with Dr. Gail Bolan and Dr. Heather O'Hara Rand. And I gotta say, Dr. Bolan, I saw that you were on there yesterday. I wasn't sure if I saw Dr. O'Hara Rand, but I know I saw you on there sneaking on. So I was glad to see you because you're such a valuable, like you were saying a moment ago, you're always happy to come, but you were such a valuable presence. And now that we're doing things a little differently, because we weren't able to have the regular sessions that you would do, we knew we had to have you to do something because you were such a valuable contributor to what we do at the National Center for Bioethics and Research and Healthcare at Tuskegee University. So before I introduce the young lady who's going to be introducing you, I just want to get a word from our leader, Dr. Ruben Warren. So Dr. Warren, can you say a little howdy, and then we move forward.
Okay, I can say howdy, and that this is an exciting opportunity to bring good people together to do good things. I think, as you said, Dr. Hodge, was given a lemon with the coronavirus, and now we have some lemonade. And so, as we continue to explore and discuss, I'm excited about this afternoon. So let's let the train move forward.
All right. Thank you very much, Dr. Warren. We sound like radio announcers. We sound like one of those people in the morning, Charlemagne the God and the rest of them. I present to you now a young lady who, you know, I do not want you to think that the Barth Honor students are a monolith, because I seem to say the same thing about them, but each of them really have an individual story. And this young lady, Autumn Sprouse Brownfield, you said, but Dr. Hogg, you said yesterday that they were special to you. Yeah, but she's special to me. She's special to me in a special way. Because when Autumn first came, I sit down and meet with each of the honor students, and have a conversation with them, and then I meet their parents and so on. And when Autumn came and I sat down and she told me about some of her life challenges, and there's a kind of challenges that would make many people give up, concede, say I can't take it anymore and run on. And what she has done with her life challenges is to turn her, Dr. Warren just said, lemons into lemonade, and become just an excellent student. But not just an excellent student, but an excellent person. I watched her handle some massive distractions with grace and decorum. And so I just love this young lady. It is her intention to go on to Emory University to get into go to medical school. She has the grades to do it. She sent me her grades at the end of each semester, and they all look like the Indian park with all of these TPs, all these A's. I said, my God, she was making A's even in the most horrific semester. She was still pushing out A's. So I am just so proud of Autumn, to the point that I included her, I invited her to participate on our leadership team. The Bioethics Honors Program have a leadership team that governs the body, and she's one of the members of the leadership team. So I always make sure I'm in conversation with her and making sure that every opportunity we get to help her advance her leadership skills, to give her that opportunity. So I present to you Miss Brownfield, and she will present first Dr. Gail Bolin.
Good afternoon, everyone. So I hope everyone is doing well today. So I'm going to present to you Dr. Gail Bolan. Dr. Gail Bolan is Director of the Division of STD Prevention at the Centers for Disease Control and Prevention. A graduate of Dartmouth Medical School, she completed her training in internal medicine at the University of Virginia, in infectious diseases at Tufts, New England, and Stanford Medical Centers, and in medical epidemiology as a CDC EIS officer in the Respiratory and Special Pathogens branch. Prior to joining CDC, she served as the Chief of STD Control Branch at the California Department of Public Health. As a leader in the field of STD prevention, Dr. Bolan is recognized for her contributions in applied STD prevention research and implementation of science-based STD programs. Dr. Bolan has over 150 scientific publications. She has served as the CDC HIV and STD Prevention Advisory Committee and OID Board of Scientific Counselors, the Executive Committee of ASTDA, and Board of Directors of NCSD and ASHA. I present to you guys Dr. Gail Bolan. We also will have, sorry, I'm getting to the bio. I have to scroll down. So sorry.
That's okay, Autumn. You introduce her when she's in her turn.
Oh,
so Dr.
Okay.
Thank you.
Okay.
Unmute Dr. Bolan.
Yes, I know I need to unmute, and as most people know me, my technical capabilities are somewhat challenged. So I'm going to try to share my screen, and that's not working. I'm trying to get back to my slides that I had up earlier. Can you guys, I now can't see you, but can you see my slides? Is that a no?
No, we can't see the slides.
All right, we're gonna sorry to cause this trouble. I'm going to get out of here and start over with my Zoom. Oops. Let's get back up to the Zoom. All right, I'm going to try. Now, why is David on here? I'm trying to.
So, Dr. Bolin, at the bottom of the screen for Zoom, there should be a green button that says share screen.
Yeah, I'm trying to get back to that. I'm not. All right. I really apologize for this. I'm gonna log out and log back in because I can't get back to you guys on my
Oh, is
Zoom.
so do you only just see the person speaking right now?
I just see you speaking, yes.
Okay.
Wait a minute, let's
so
try
if
this. Okay, I'm back.
Okay.
All right, very good directions. I will try to share my screen again the way I did it last time. Why is it? Okay. Apologies. Let's see, 3 times is a charm. We look like we're back to where I was at the beginning. Excellent.
Yes,
So
there we
you
go.
guys can,
Yes.
everyone can see my screen. Apologies, I got to talk faster now. Used up too much time with technology. So anyway, first of all, I really want to thank Dr. Warren. I have really enjoyed getting to know him while I've been at CDC. And I always say the highlight of my year is to come to Tuskegee and observe and learn from what the Public Health Ethics Institute is doing, because we at CDC are committed to work with Tuskegee, and as they are expanding, it's been fun kind of looking at the journey, to every year make sure that we, and this is the 23rd year of commemorating the 1997 presidential apology for the U.S. Public Service syphilis study at Tuskegee, a horrible situation of our past we all must never forget, but I think some really good things have come out of it. It's again like lemonade. The families have been amazing, and the foundation that they have established, I encourage all of you to get involved. And I think the support the foundation is giving students at Tuskegee and others, we at CDC are really proud of. So today, as a government employee, usually my work is to share information about the health of the nation in the field of STIs. We know it takes a village, and we know there's a lot of work to be done. And I would say that this year is very timely for me to be discussing sort of focusing on women and children, not that we also don't have huge health disparities with men. But today I just want to give you sort of a state of the state of the situation of STI vulnerability, especially among women, because when you're dealing with women, you're also dealing with their children. And I have to say that I have no conflicts of interest, and that the findings and conclusions in this presentation are those of the author and do not necessarily represent the official position of CDC. So I'm going to talk a little bit about STDs. Maybe some of you in the audience haven't thought about them for a while, and also talk specifically why women have some very unique situations that place them incredibly vulnerable to these infections, which are contributing to some very significant health disparities in our nation right now. And I'm looking forward to a very robust discussion about sort of the ethical issues that are under behind these disease rates I'm going to discuss, and see what kind of creative solutions we all can contribute to these problems. And that I'll give you an overview of sort of the resurgent data and what we think the drivers are right now for women in the United States, especially around our problem with a congenital syphilis epidemic occurring even before COVID. And I do want to make a few comments about COVID, because there's a lot of similarities about vulnerabilities and communities and how we need to approach things. And I think we in STDs are not as surprised of some of the findings related to COVID, related to community engagement and mistrust, and the importance of working with communities and also getting communities to help solve the problems. So there's a lot of similarities, and I'll just give you a little update on what's been happening with COVID on impacting our STD treatment and care, because a lot of our work this year has been diverted to COVID, obviously because it's a significant pandemic of many centuries. So we'll share with you on that. So just wanted to, let you know that we refer to the STIs as the hidden epidemic. I was just listening to my director, Dr. Redfield, prior to this Zoom in his update for division directors, and he actually called COVID a hidden epidemic. But the reason why STDs are such a challenge is that most of our infections do not cause any symptoms. So people don't know that they're infected. So they don't realize that they need to access healthcare. They see providers who are not knowledgeable that there are no symptoms, so they don't think about testing their patients. All of this provides opportunity for infections to go undetected, complications to happen, and continue sort of disparities within communities in the United States. The other thing I will say is that, with the exception of HIV, which is a sexually transmitted infection, STDs are largely excluded from public discourse. They were stigmatizing in the 40s, and they still are stigmatizing. And, we are not talking enough about healthy relationships and sexual health and holistic care, because they don't think, just focusing on diseases and cases. And I always like to say there are people behind those cases. We're not going to reverse these unfortunate trends that we're seeing. Again, our sexually transmitted bacterial diseases account for 5 of the most commonly reported conditions in public health. And we estimate that the medical costs, basically are about $8.4 billion a year. We actually have a new updated number that is on this slide that we've recently been doing some new estimates of costs and incidence and prevalence infections. Those will be coming out in January. And we estimate direct annual costs are about $17.5 billion annually. Now, just to sort of orient you, we have many STDs, we have many populations, and we have many health consequences. But as you can see on this slide, there are 4 main health consequences of sexually transmitted infections. Obviously, HIV is incredibly significant, but we also now are learning that STIs in themselves are contributing to HIV transmission. If you're infected with an STI because of the biological properties of either an ulcer that's broken down your skin barrier or inflammation that you see with chlamydia and gonorrhea, you're more likely to acquire HIV than if you did not have that STD. So we know that STDs actually are now playing more of an important role where we are in our phase of the HIV epidemic. But if you look at our other adverse health outcomes that are causing health disparities in the United States, certainly chlamydia and gonorrhea get into the upper reproductive tract of women who are infected, and we know result in pelvic inflammatory disease, chronic pelvic pain, and the worst outcome is impaired fertility, so that when you are choosing to have a family, you may not be able to. We also know that syphilis and herpes, especially in pregnant women, have very severe outcomes, including mortality. We have stillborn babies from congenital syphilis, and neonatal herpes is the most significant outcome of any type of herpes infection, and they also can result in death in the neonate. So these are things that we're very concerned about, and we're even more concerned when we see disparities in this country related to these outcomes. And then lastly, we also, HPV is a sexually transmitted infection. We know it causes reproductive tract cancers, first known for women. We know there are also reproductive tract cancers in females. And all I have to say is I think the HPV vaccine is one of the greatest biomedical discoveries of the century until we had HIV medication that came along, at least in my career. And it is sad for me to see how underutilized the HPV vaccine is. And I will say that vaccine probably is also going to be beneficial to oropharyngeal cancer, which is a very serious cancer in older adults. So I don't want us to forget that we do have one vaccine preventable STI. Actually, we have a couple, hepatitis B and hepatitis A as well. Who's at risk for STIs? We know young people, 50% of our burden is among people less than the age of 25, and they only represent about 25, especially adolescents only represent about 25% of the sexually active population. Obviously women, which I'm going to talk about today, we're seeing huge disparities also in gay, bisexual, and other men who have sex with men, and in racial and ethnic minorities. So to discuss a little bit about the factors contributing to why women, end up having more of these infections, it's as everything in STI, it's not one size fits all. It's not monolithic. It is complicated. So we know that women are more likely to be infected with STIs. There are certain factors in certain relationships with power dynamics where women don't have full control of their sexual health or their sexual practices. That contributes to these higher rates of STIs. We also know right now there's been a lot of work with microbicides and other prevention technologies, but so far our main prevention technology for STIs is condoms, which is a male-controlled prevention technology. We're hoping there's continued biomedical advances in that area. And then there's just anatomical differences. I mean, the vagina is very different than the penis. And when you're exposed to an infection in the vagina, that exposure lasts for quite a number of hours or days. But for a male, their exposure from a female is only during the time of sexual intercourse, so it's much briefer. So there's basic biology as to why women are more likely, and especially younger women. The cells that chlamydia and gonorrhea like, they're called columnar cells. They live at the end of the cervix, and before you go through puberty, those cells are readily exposed at the end of the cervix. So they're much more likely to become infected than in an older woman where the cells have migrated up inside the uterus. So these are biological things we don't have a lot of control over, except trying to use more prevention technologies. But there's just basic differences in the anatomy of men and women that put women at higher risk for STDs. And then women also don't have very specific symptoms. They may have a little discharge. Well, everybody has discharge. Is it a new discharge? Is it an abnormal discharge? Certainly men who have burning on urination realize, this is not quite right. I need to go in and get health care. So a lot of women don't seek health care because they don't recognize that their symptoms are significant and are symptoms of chlamydia, gonorrhea, herpes, or syphilis. And then we still live with a lot of social stigma and discrimination and embarrassment where women are not getting care from culturally sensitive providers in the healthcare system. And that also applies to, racial and ethnic populations as well as MSM. So there's a lot of work we need to do there. And then women are more difficult to diagnose. Sometimes the tests don't work in women. We hear a lot about women's health care, that studies are done in men for heart disease. And then we're trying to figure out are the heart medicines working for women? Women are biologically different than men, and they need to be part of research. They need to be part of evaluation so that we ensure that they are getting the best care that they deserve. And then as you saw from my previous slide, they suffer from much more severe biological and social consequences from these infections. So I'm going to talk a little bit about, because we won't have time for discussion, the epidemiology. Chlamydia has always been a big women's problem since we learned about this new bacteria back in the 60s. We do have good tests. They're easy tests. These tests now, you can just collect your specimen yourself with a vaginal swab. You can do it at home. So we've got a lot of opportunity to identify these infections in women, but you can see that rates in women have always been significantly higher than men. We're a little bit, encouraged in 19. Now, again, our 19 data are preliminary because we still have states that haven't submitted their finalized data to us at CDC, that maybe we're seeing some slow progress in terms of this increasing rate. But we also look at it, we're so concerned about people less than the age of 25. And as you can see here, compared to women over the age of 25, we're talking about rates of chlamydia in young girls, you know, almost up to 4,000 per 100,000 women of that age group. So even if maybe the curves have plateaued a little bit, we've got a lot of work to do because that's an incredible disparity, which will result in the complications of PID and infertility if not diagnosed quickly and treated quickly. The main strategy we use for STD control, we're very dependent on the healthcare system. Another area where there's work that needs to be done in terms of health disparities. I always like to say it's great that more people have health insurance. We still have a lot of people that don't have health insurance. This is looking at Medicaid and commercial health plan data on women aged 16 to 25 who were tested for chlamydia by enrollment. We do recommend annual screening for this group by the U.S. Preventive Services Task Force. So, you know, only getting up to about 50, 60% to me is substandard care for these women. But we also know even if you have health insurance, you may not actually access care because you're concerned about trust, discrimination, stigma, a variety of things that happen in our healthcare system. So these numbers still tell us we have a lot of work to do. We clearly see higher screening rates in the 21 to 24-year-old age group, but we're also very worried about the reproductive health of our teens in this country. And you can see that, you know, if you're in the Medicaid program and actually come in and get tested, you know, we're not even up to 60% yet for screening coverage annually. And if you're in a commercial plan, where we know a lot of sexual histories are not even taken, screening rates are less. And I just want to remind people, not only one infection of chlamydia can cause pelvic inflammatory disease, which can lead to ectopic pregnancy and infertility, but there's also good science showing if you get infected a second or third time, third infection with chlamydia, I mean, you have a relative risk of 6 for developing these adverse health consequences. So not only do we want to identify the first infection, but we want to be focusing on making sure those women do everything they can to protect themselves from becoming ever infected again. Now, our sadder story is what we're seeing with congenital syphilis and syphilis among women of reproductive age. The purple line looks at the rate of primary and secondary syphilis. That's the infectious form of syphilis. So it's almost like looking at incident cases. You know, just having a positive serology doesn't allow us to really determine when you were infected. You may have acquired that infection 20 years ago. Maybe you acquired it, you know, within the last year. But when you have symptoms of syphilis, primary causes ulcers and secondary causes more of the skin manifestations and mucous membrane manifestations. We know you recently acquired this infection. And we also know from previous epidemics that we've seen in this country that when you start seeing syphilis rise among women of reproductive age, then you start seeing cases of congenital syphilis. And I was hoping that maybe 2019 was going to bring us better news. And in 2020, we don't even know where we are because we're not getting cases reported to us from health departments, which I'll talk about. We're almost up to 2,000 cases of congenital syphilis in this country, which is getting close to the highest number of reported cases ever since we've been collecting data since 1940. That is startling. And, you know, it's concerning to me as both an infectious disease physician and a public health official that in general, in our country, for the amount of money that we spend on healthcare, we should be able to prevent congenital syphilis. We have the tools. And to me, every case of congenital syphilis is a sentinel event that suggests a failure of the public health system and a failure of the healthcare system. We do look at our cases by geography because we do recognize that where you live matters for a lot of diseases, and STDs are among them. And if you live in a community with high prevalence of STIs, including syphilis, and you have one episode of unprotected sexual intercourse, you're more likely to get infected than someone who lives in a community with very low rates of disease, because your chance of running into the infection is much less. And if you live in a community with no disease, you are not going to get infected. So it takes two things to happen in the world of STIs. You've got to have exposure, and you've got to, have the infection in the community. So right now, although congenital syphilis is increasing in other states, we know that most of our cases are in the South and in California. We are very interested to understand what is going on in Mississippi. Sometimes when we get low rates of disease at CDC, we say, oh, well, they're just not, detecting it. But, Mississippi's had some good maternal child health programs in the past. So we really need to see, are there best practices there we can learn from? But basically 70% of all congenital syphilis is either in California, Arizona, Texas, Louisiana, or Florida. And we are certainly prioritizing our federal resources to try to address this issue. And we are obviously having to decrease other activities because our resources that go to the states have been pretty stable for a number of years. So what have we learned about the factors, underlying risk factors of women who have syphilis and who have had a baby with congenital syphilis? Well, we know for decades that in any individual that has multiple sexual partners, especially concurrent partners, is at more risk of STIs. We know in the past substance use disorders have been prominent, but they are now becoming, I'm going to share on the next slide, become very prominent among women, which is a symptom of, sort of the social fabric of our society. And we are now starting to see a lot of these women have unstable housing. We've not seen that in the past epidemics or rises among women in the United States. So unstable housing is now a new factor. And the other new factor is these women are now intersecting with the our justice system, which we know we have a lot of work to do on. It used to be that it was the male partner that would, had a history of incarceration. Now we're actually seeing these women are in the criminal justice situation for a variety of reasons, and this is very concerning. We also know we have pregnant women that basically have no prenatal care, and I'll talk a little bit about the reasons for that. In 2018, these were not older women, these were relatively younger women. 60% of congenital syphilis mothers were 20 to 29 years old. The most common race actually varied by region. So Black race was more common in the South, the Midwest, and the Northeast. I would say the Midwest and Northeast have a smaller number of cases. And Hispanic was the most common ethnicity in the West. And we're also concerned, we've always had higher rates among African Americans and Native American, Alaskan Native persons, and those continue today. So looking sort of at the drug use, you can see we have limited data at CDC. Sometimes locals have more data. A lot of work needs to be done here. Everyone's hearing about the opioid epidemic. They're hearing about it's associated with HIV and Hep C, but it looks like we're also having an intersection with the opioid, and I would say broader substance use disorder. Because not only is heroin, again, we start with small percentages, but the curve is steepest and disparity is steepest among women. Meth use is much more common, and that's where I feel we really need to talk beyond just the opioid epidemic. We need to talk about substance use disorder epidemics in the United States. Women, again, have a steeper curve for injection drug use or having sex with a partner. So clearly substance use disorders are a factor contributing to congenital syphilis in this country that we need to work on if we expect to bend the curve. We've also looked at the cases to say, where are missed opportunities? Did they have prenatal care? Most states have laws, you have to be screened for syphilis at your first prenatal visit. Were they getting screening, at their first prenatal visit? Were they getting timely treatment if they had a positive test? And then we do recommend that if you're in a community with high prevalence, and we're trying to get better data on what that high prevalence means, but to me, if you've got congenital syphilis in your community, one case is enough. You should be screening pregnant women during the beginning of their third trimester, because we have women that are acquiring syphilis during their pregnancy. Their first test may be negative, but if you don't screen at the beginning of the third trimester, you're going to miss that they are infected. And at that time of syphilis, that's the highest organism load that goes to the fetus, and pretty much the fetus is universally infected. So nationally, we've got 28% of women no prenatal care. We've got a few that do have prenatal care, but for some reason their provider isn't screening. 31% have a positive test, but they are not getting treated. That's a problem with our healthcare system. And then we have providers that assume if they tested the woman once, that's good enough, or they think they're low risk. And these women are not getting a third trimester screen, so we're missing the opportunity to identify these cases that were acquired during pregnancy. What's interesting is that there are great geographic differences. In California, there are a lot of women with 41% no prenatal care. And we're learning about these women really have fallen through the social fabric of our society. They're afraid to go into the healthcare system. They don't trust it. They're afraid they're going to lose their baby. And if you hadn't read in the newspaper a month or so ago, a woman in Los Angeles was actually charged with murder because she had a stillborn baby and she was using meth. So I think women care about their children. They care about their pregnancies. They want a healthy baby. And so we have got some major social determinants of health here that are driving women away from healthcare. Now in the South, we've got a different scenario. Most of the cases that could have been prevented were because women did not get treated. And if you don't know, to treat syphilis, you have to give an injectable form of penicillin, which a lot of OBGYNs just don't have available in their office practice. So what happens is the providers are referring these women to some public health clinic somewhere in their county, and no one's tracking, did the woman ever show up to get treated? So the women are getting lost in the system and not getting the treatment that they need until they deliver a baby with congenital syphilis. So these are things that we need to be paying attention to. These are the vulnerabilities. These are the social determinants of health. These are our social fabric of our society. And until we can, sort of tackle these issues, the health of our nation in terms of syphilis and congenital syphilis is not going in the right direction. So we're trying to, sound the alarm, let people know that just counseling and education and trying to screen our way is important. These are all, necessary, but they're not sufficient. And we really need to start looking at, really getting down on the health pyramid and really starting to address social and economic factors. Because if we can decrease poverty, we can reduce economic inequality, improve education and housing. Think of all the health conditions we could improve. It's not just STIs, it's just that we're seeing it, is what we're learning about our epidemics. And we obviously would love to have the context where making the individual healthy, individual's decision, default to the healthy decision, but we lack a lot of really good prevention tools in the STD field. We haven't had a lot of biomedical advances. If you want to know, we're still using a syphilis test that was created in 1906, and we're still using syphilis treatment that was created in 1940, and we've had no new drugs in the pipeline and no new diagnostics. So another conversation to have about why we're seeing health disparities, because the lack of biomedical investment in STIs in our country. So a few comments on COVID. I'm just going to go quickly because
Dr. Bolin, you have frozen. If you could hear me. Dr. Bolin, you may need to exit and re-enter. Okay, I think what we can do now while we wait for Dr. Bolin. Can everybody hear me? Everybody hear me? Okay. I think what we could do now as we await Dr. Bolin's return is Autumn, if you could gear up, wait, she might be coming. If you could gear up to introduce Dr. O'Hara Rand, then we could kind of keep this as seamless as possible. So introduce Dr. Rand now, so by the time Dr. Bolin gets back, then we could continue from there. All right.
Okay. Dr. Heather O'Hara Rand, originally from St. Louis, Missouri, attained her BS in chemistry from Tuskegee University, MS in organic chemistry from Georgia Institute of Technology, and MD and MSPH degrees from Meharry Medical College. She is a board-certified physician in occupational medicine and general preventive medicine and public health. As an associate professor in the Department of Family and Community Medicine at Meharry Medical College in Nashville, Tennessee, Dr. O'Hara Rand serves as the director for the Preventive and Occupational Medicine residency programs, as well as the director of student and employee health. Her residency training emphasized helping others to achieve and maintain a healthy lifestyle related to understanding nutrition, physical activity, and the harms of tobacco, alcohol, and illicit drug use to promote overall wellness. She has interests that span the topics of obesity, breast cancer, integrative healthcare, and workplace wellness and safety. She has published in peer-reviewed journals on studies related to migrant farm worker safety perceptions, perinatal factors, and breast cancer risk, integrative medicine, adverse childhood experiences, and sports nutrition needs before, during, and after exercise. She utilizes her areas of focus in multiple settings to provide education to students, residents, healthcare providers, and other workers. Dr. Heather O'Hara Rand.
Thank you, Summer. That was very quick and nice. I appreciate it. So I'm guessing we're gonna, give Dr. Bolin her last few moments with her presentation when she comes back on. But just to kind of start a discussion off of the things that she brought up already. One of the things that definitely came to mind was that while the Uspstf recommendations, the United States Preventive Services Task Force recommendations are there to include screening patients who have high risk of STI contraction, as well as counseling and other things, both in pregnant women and non, that clearly that's not enough based off of the information that Dr. Bolin has provided, and then how to get it so that it can be enough, that it can be something that people actually utilize. And so one of the biggest things that, especially just being in the clinic, that I've seen is the stigma around these things, right? So people not being comfortable with talking about sexual activity, or even the potential that they could have an STI. And so increasing the ability for people to understand that this is something that has been normalized. I'm not reaching out to you because I feel like I'm looking at you and I think that you might be engaging in unsafe sex practices. I'm reaching out to you because just out of general public health need, we need to make sure that you're safe and that the people that you may be engaging with are safe. And it needs to start at an early level, because unfortunately, as we've heard and continue to see, people are having sex younger and younger and younger. They're making pacts to have sex. They're, making pacts to get pregnant together in high school and middle school. And these things, these are unsafe sex practices. Clearly, they don't know what little Johnny may or may not have when, they decide to lay down with him. And so normalizing the actual participation in screening and STI testing is one of the things that absolutely has to happen. And to do that, we need good, efficient screening methods that don't provide that opportunity to feel like you're being judged. And this comes from both training in all of the healthcare related fields of compassionate, culturally competent care. You have to know how to talk to people. You have to know how to engage with them. You have to know how to let your own implicit biases stay in the background while you're caring for that patient. And, unfortunately, this isn't something that is common. Thankfully, it's becoming more common, but definitely not as common in the medical education for physicians, nurses, PAs, what have you. I know I've worked on a committee with the Tennessee Department of Health in primary prevention, and we're trying to understand more about the things that medical schools, nursing schools, PA schools, all those types of places within Tennessee are doing to increase awareness around social determinants of health, culturally competent training, and things of that nature. And while some have definitely started to make strides in providing that to their trainees, there's still definitely a dearth of application within these institutions across the board. And we would imagine that that would probably extend, and it looks like Dr. Bolan's coming back, but extend beyond, Tennessee as well, that this is an issue also. So I'm going to let Dr. Bolan finish up and we'll come back.
Unmute Dr. Bolan. Unmute.
My
Okay.
apologies. I have been Zooming for I don't know how many months, and I've never had my internet disconnect. But anyway, apologies. So I would just like to sort of wrap up and just say that, COVID has challenged us even more. We have STD clinics that had to close. They didn't have PPE. They've had to limit services only to essential, which is symptomatic. At least the good news is prenatal care seems to still be happening in this country. We also have a new problem that we had some medication shortages with azithromycin when alternate COVID medications were being recommended by some people. But now we're having trouble with testing supplies, not for syphilis, but for chlamydia and gonorrhea, because there's just shortages of everything, swabs, reagents, and they're being used for COVID. So I just feel we are at a point that I'm feeling about the social fabric of our society. I think there's a lot to discuss about, how we're going to move forward, and having people like you and the students that are on today are really, really important to us in the field of STIs. There's a lot of work to be done. We need communities involved. We need everybody. And I really appreciate the time today and look forward to the discussion. So go back to your response time, Dr. O'Hara-Rand.
Thank you, Dr. Bolan. And just to kind of briefly let you know what all I've already said, I talked about the need for USPSTF recommendations to actually be implemented, and how to do that basically by normalizing those questions, those screening exams, those things that will help to decrease the stigma around having these things discussed in a clinic environment, or even wanting to come in and have those screening tests done. You mentioned in your talk about, wanting to push the button, if you will, towards making healthy lifestyle choices. And that was one of the things that I know I did. I was getting tested every year for any number of things. And it didn't matter if I was engaging in things or not. I just wanted to know for myself that I was in the clear. And I never thought anything about it. I never felt like I was, being judged or anything like that. But I know that there are people that do. I've seen those faces. I've seen those looks when I've talked to patients about what things we're supposed to do at this visit. Being in preventive medicine, that's my wheelhouse. That's what I'm here for, is to make sure that you're doing all the things that you need to do to maintain a level of health within your own self and within your community. But people kind of get taken aback. Well, I don't really want to talk about that. You talk about how, in what ways are you engaging in sex? And they don't want to mention that they're having anal sex. They don't want to mention that they're having oral sex. There's some sort of faux pas around that, and we have to break that barrier down. And that comes with, as I mentioned before, increasing the culturally competent training of healthcare providers across the whole full spectrum, to make sure that they know how to talk to people and engage in these types of conversations, and are comfortable with their own implicit biases, to make sure that they leave that in the background and bring forth empathetic way of discussing these things with their patients. And, again, I've introduced to students when I've had opportunities, there are, tests out there that you can take to look and see, where are your implicit biases? What things are you not recognizing in yourself that, because clearly you don't know what you don't know, that, you can now take these tests and know, okay, I tend to have more of an affinity towards people who are light or white or whatnot. And if they're darker skinned, I don't really have the same level of understanding or empathy around those individuals. And it's important to know these things, because if you don't know, then you can't fix it. So it's part of that need for training And part of that understanding that if you don't understand these things, you will be a part of the problem essentially in the future. Other things that come to mind, I can't tell you the number of times I've had patients who don't even realize that HIV is still a thing. They think, with Magic Johnson out there and have, basically it being undetected and things like that, that it's just, it's curable and it's really not an issue anymore. And, and so I think the messaging has been lost. Back in the 80s and 90s, we were being bombarded, which in a good way, with that messaging, wrap it up, don't engage in unsafe sex, whatever, blah. And we're not seeing that as much anymore, and unfortunately people look at that as like, oh, well, it must be okay now. I won't be as, I can't possibly get it because there just aren't a lot of people who have it now. And that's the worst thing that you can think, because it's still out there. It's still very much active. And it's still very much possibility that you can get it. So trying to, do some of the things that were being utilized before to help people understand, and especially with the resurgence of syphilis. When I talk to people about, you brought that up, and I'd already knew that had been, creeping up. And when I tell people about it, they're like, whatever, syphilis, that's like from way back when. They don't want to believe that these diseases that were more common, from our textbooks, right? Like, I remember learning about syphilis when I was in med school, but we never saw a case, to being like, you know what, I have to consider that there's an actual case of syphilis when a patient comes in with a painless ulcer, as opposed to just kind of knocking it off or brushing it aside and not believing that somebody could actually have syphilis because I had never seen it in my training. So again, increasing awareness around those things and making sure that people are staying up to date on that information is a part of this, and increasing the awareness around this in the community. It's the numbers that you presented are shocking as far as congenital syphilis is concerned, just because it's preventable. I mean, we don't have to have babies who are impacted the way that they will be through this illness. And I know I've had 2 kids and I'm pregnant now, and my 2 kids, yes, they have to do the screening for HIV and syphilis and everything else at the initial appointment. But moving to Illinois, so apologies, my bio is a little out of date here since I submitted it. But moving to Illinois, and when I went to my prenatal visit, I think last week or the week before, they were like, oh yeah, and we'll be drawing your labs again for HIV and syphilis and whatnot. And I'm like, huh? I mean, I'm pretty certain that I don't have any of those things at this point, but I agree with it in terms of seeing the cases rise, and I'm fine with it. I'm not going to, decline it, but this is a thing where, if people aren't being educated that these are the things that need to happen to make sure that our children and our women are being protected, then it's not going to change. So increasing the messaging, increasing culturally competent education, so that we can actually engage in these discussions with our patients, with our communities, and making sure, and I know we're running low on time, so I want to leave some minutes for discussion, but in normalizing this process, making sure that we are not judging people based off of their decisions, because it's their decision ultimately. You mentioned the whole trying to make it so that people make healthier choices, but as we've seen with COVID, people just don't always get it as far as what the healthiest choice would be for them, for their community, for their families. And so we have to figure out how to turn the needle so that no matter what, even if they aren't making the most healthy choices, they're at least getting the care that they need. And healthcare needs to change. It needs to include the time that's needed to see patients and discuss these things. It needs to be affordable. It needs to provide the level of interaction that is going to be conducive to having these tough discussions with people from the ages of, 12, 13 that are making these pacts to start having sex and having babies to, well beyond when we get up in our years. So I'll stop there because I don't know. I think it's 2 o'clock, but I'm not sure that this is supposed to end.
You're right. You're right on the money perfectly, because now we open up the questions, and there are 2 questions in the queue. Autumn will be reading questions, but before the questions come, I take a little executive privilege and I ask the first couple of questions, which will warm up people to ask questions. Before I say that, I want to encourage all of the attendees to. This is a judgment-free zone. There's no judgment. You can even ask a question anonymously. There is no judgment. So ask your questions. That's the purpose for this conversation. We're trying to save. We're trying to save lives. We're not interested in hurting people's feelings. We're too concerned about saving lives. And Dr. Bolan, thank you very much for such a very in-depth and terrifying presentation. And Dr. O'Hara-Rand, thank you also for such a thoughtful response. So the question I have, actually, I've jotted down 2 questions, and one, Dr. O'Hara-Rand, you actually spoke to it, but I want to bring it up again because I want us to take just a couple moments and reflect on it. There's 2 questions here. The first question I have is, you said, Dr. O'Hara-Rand, that that you don't see too much advertisement like it was in the 80s and the 90s about HIV. And I want to say that I don't see any, actually. And I'm concerned, I'm extremely concerned, because the silence kind of gives a kind of implicit acceptance to everything is okay, that we're fine. You could go now and go back to as you were, and so on. And I bet Magic Johnson, the good of Magic Johnson is he have the Magic Johnson clinics now. And when Magic Johnson was first diagnosed with HIV, he said, the language is a little off, but I get what he's trying to say, that when God gave me this virus, he chose the right person, because I'm the kind of person who is empathic and caring enough to be an ambassador. So he was right there in terms of, he set up the Magic Clinic to have free medication for people HIV and AIDS. So you have the kind of double-edged sword that, but because he's so healthy still, it seems like, wait a minute, it's not that bad. And with other medications that are coming out. So I want to know, what else can we do to kind of, we want to have people encouraged to test and utilize the medication that's available, but also to have some caution. What else can we do to help there? Because I remember in the 80s and the 90s, you recall just about every week, we heard of a new celebrity who died of AIDS, a cousin or family member who died of AIDS. I don't know the last time I heard of someone who died of AIDS. So that's the first thing. Is there anything else we can do, especially the National Center for Bioethics and Research in Healthcare? Dr. Warren and I have joined with another group to create a HIV journal, session edition journal for next year. But what else can we do to make sure, even, as a matter of fact, we would love for you all to participate in that journal. I just let me put that out there also. But what else can we do to get the message across? The second question is that, and Dr. Randall Bailey is online with us, and so he might want to chime in. Dr. Bailey, wake up, but he might want to chime in. Here's the thing. The church, and Dr. Warner, we talk about all the time, the church has nothing goes on in the Black community without the church being at the center and the mosque being at the center. And we so often church parishioners go to their pastor before they go to their doctor. And W.B. Du Bois talked about the talented 10th, educate the pastors, educate the teachers, and they could spread the news. What can we do to get pastors back in conversation and some of and the reason I said Dr. Bailey is because the view of sexuality in the Bible is still very narrow. So what can we do? So number one, to promote that, to re-promote HIV and AIDS is something that needs promotion. And number two, what can we do from the liturgical, from the ecclesiastical, from the church side that says that we need to kind of shift the way we talk about sex, and in such a biased way that it creates judgment and a lack of transparency, particularly for our young people. So Dr. Bolan, Dr. O'Hara, Dr. Bailey, any way you want to answer.
Well, I can, oh, sorry, Dr. Bailey, did you want to respond to the?
Yeah, I think the difficulty is that we have bought into sexual ethics, which are presented in the Bible, which are destructive. And we don't want to give them up. And we also have to look at the sexual misconduct that goes on in churches among the leadership and the members, and how that functions. And we don't want to really deal with presenting real consequences to those behaviors. So that would be, my, my concerns.
One of the attendees, participants, talked about the, let me see here, Joe Valentine, I think is what the person's name was. So conservative religious dogma often impedes open communication, i.e. human sexuality or sexual health. And I would agree with that because the Bible tells us, sex should not be occurring until after you are married. But the issue is that society has—
Only for women. Only for women.
Well, only for women, yes.
According to the Bible, men can do whatever they want.
Exactly, true. And so by the time the men get to us and we marry them, now we're going to have the diseases that they've picked up. But anyway, that's neither here nor there. But the point being that I agree with that, my grandfather was a pastor. I grew up in the church, and it was just something that was not discussed. You just listened to the word and you knew, okay, if I'm going to do this, I can't let anybody know. And that has to change because unfortunately, they're doing it. These kids are having sex early and earlier. And if we refuse to talk about it because we're so caught up in religion, we're never going to get a hold of this issue. And so as far as, the church goes, I would argue that the pastors, officiants, heads, however they're called, need to understand this and understand that by not talking about it, they're perpetuating the issues that we have and potentially, and not even potentially, increasing the risks that are going to be continued with increasing STI contractions and unfortunately the issues that come with that, which include infertility and adverse pregnancy outcomes and other things like that. So I would just say we have to have real discussions with our church leaders and let them know that, this is a public health issue. And if they really want to get in and help society, right? So that's what all of this is really for, is to help the public, to help the health of our society to actually last and be able to, continue in the most healthy manner possible. And that's not just around STIs, that's around many other things as well. But, as just in this topic today, giving that a serious look.
Yeah, I would say that when my brother Mark died after 3 years struggling with HIV and AIDS, when I called the church to give the death notice to go into the paper and into the bulletin, I said, in lieu of flowers, please make contributions to Aid Atlanta. And the church secretary said, you don't want to tell anybody that. I said, we've been telling you that for 3 years. You refused to listen. You didn't help us as we went through this, but we are not hiding because we never hid from it. But the view of the church was we shouldn't have had that in the bulletin.
And I would sort of add, I think this extends beyond even churches. I think our society, just struggles. It's a silence. It's not something people are comfortable with. It comes with stigma. It comes with judgment, misinformation, and I don't think we're serving our children well. So I think I think there's a role the church can play, because I'm a great believer that if you empower people with the right information, they can make good choices for themselves. And that includes adolescents. With my kids, they heard about STDs on the phone while I'm driving around going to work. And we started talking about, sexual behavior in kindergarten. I mean, it's not like smoking, where you say to your children, just don't do that. That's really bad for you. But we are human beings, and human sexuality is something that, I would say the vast majority of citizens in the world embrace. And you need to do it in a way that is healthiest for you at the time that's right for you. And we've got challenges that, parents want to talk to their kids, but they don't know how. We're not equipping our parents. We're not equipping our clergy. We're not equipping our teachers. And we're not equipping our doctors. I mean, how many of you in the room right now, the last time you went in to see your clinician, they did a sexual history, a comprehensive sexual history, gender of partners that you're having sex with, not just assume because you're married, you have one partner and you're in a monogamous relationship. And if we can normalize these things, I do feel our youth have a lot more fluidity and knowledge about sexual behavior than I think a lot of older people have, because they have been on the internet, they talk to their friends. That's a plus and minus, because are they getting the correct information? So I think it's key to relationships that we look at it from the standpoint preparing people for healthy relationships, and what you can do to get empowered to do that. And I think the more open communication across the board with partners, with parents, with clergy, with your best friend, with your trusted adult in your life, because it's an evolution. I joke and say we spend hours teaching our kids how to cross the street, and we don't do anything to prepare them when they're in a situation where, peers are doing different things and they don't really feel comfortable and don't know what to do.
All right. Thank you very much, each of you. And now I turn it over to Ms. Brownfield, and she will ask the questions that are in the queue.
Okay, so considering the stigma issues, what kind of advice can you give women when it comes to talking about STIs with their male partners?
So to that, as often as women are the ones who have to kind of approach these topics, I just think you just have to do it, not in a, again, being mindful of people's hesitation around this topic, around these topics, but being, open and honest. So, one, if you can't have these types of conversations with the person that you're considering having sex with, you may want to reconsider having sex with them, because there's clearly some lack of trust or something that is a disconnect to being able to actually know what it is that they may have going on with them, so that you can protect yourself, because ultimately that's what you're trying to do. You're trying to make sure that you're not engaging in an activity that's going to put your life at risk. So if you can't have those conversations with somebody, if you don't feel comfortable having those conversations with somebody, it may be time to reconsider actually even engaging in those types of activities with somebody. But I would just argue that we have to get comfortable with it. We have to stand in a mirror and start asking those questions and get comfortable asking those questions. Get comfortable asking, how many partners have you had? Have you ever had sex with somebody of the same sex? Have you ever engaged in this? Have you ever engaged in that? Because these are the questions that you need to know to understand if somebody is potentially at high risk. Even if they've tested negative, say 6 months ago, it doesn't necessarily mean that they're negative now. So you have to be able to get comfortable with asking those questions for your own sake, for the sake of any potential outcomes that may come, like a pregnancy, and just for your own good mental health and health of the relationship itself. Dr. Bolan, I see you have.
Yeah, I would say that practice makes perfect when asking difficult questions, and the more you do it, the better you become of it. And I think another point that we certainly use in public health, because we're also challenged by, quote, contact tracing. And, contact tracing involves a knock on a door of someone you're not expecting. They are trained, if a mother answers and they're looking for an adolescent, they'll say, well, I'm from the health department, I'm from the Department of Ed or something. They've got creative ways to maintain confidentiality. But I think the point is it's all about health. And if you can say to someone that you're, in a relationship or thinking about a relationship, I really care about your health, and I hope you care about my health. And, in this day and age, there's a lot of new behavioral norms. I mean, with these geosocial apps, you can, go out and, find partners so much more easily than it was when you had to go to a bar and kind of start a conversation and figure things out. So there's a lot of things that are very different now. And I don't think anybody can know, everything that they think they know about anybody. Not that you don't want to be not trusting, but I think it gives good foundational trust to have these conversations, be able to ask these questions early on, and sometimes I think it's good to say to your partner, you know what, let's go in and get tested together. There's a lot of couples now that do go in and get tested on a regular basis. They may have an open relationship. They may know that, people have other partnerships at sometimes. So I think we just need to, again, it gets back to the destigmatizing open conversations. And the more we do it, and the more, on an individual level, eventually, there's going to be a lot of people doing it. And it's the same conversations that parents need to be having with kids. All parents, I think, want their kids to end up in a healthy, loving relationship, that they're very happy. And then maybe have some grandkids too or something. And that's actually a story that I've heard from parents in some of the work I did when I was in California, that when you started saying, if you don't have these conversations with your kids, you may not be a grandparent. That actually resonated with a lot of parents. So it's all about, honesty, trust, and communication.
Okay, the next question is, I know there is a vaccine for HPV for children, but is there a vaccination for adults and or treatment for adults? Are there any particular symptoms?
So I'll just give you sort of what we CDC puts out, again, because we try to help providers be knowledgeable about management of STIs. We're known for our STD treatment guidelines, which are evidence-based and I think considered the standard in the healthcare community on how to manage patients with STIs. We're in the process of getting our next edition out. So, and that's not common for CDC, because most of our work is public health, and most of our docs at CDC are not clinicians, they're medical epidemiologists. So first of all, there is a vaccine. It is recommended that you start vaccination early, even before sexual activity. It does not make people become sexually active. And it's ideally recommended, it can be as low as 9 years of age, but generally it's recommended for girls and boys now, independent of sexual orientation, to be vaccinated when they're 11 or 12. And then if that doesn't happen, because there's obviously a series and it depends on which vaccine you take, whether it's 2 or 3 shots, people need to get caught up by the age of 26. HPV is incredibly common. And they've done studies among low risk, young adults and found prevalences of 60%. And it seems to clear, or it causes no further problems in the vast majority who are infected. So there's no recommendations. It's up to sort of a conversation with your clinician, if you're over 26, of whether or not you should be vaccinated. But at least the evidence doesn't suggest by that time it's really worth vaccinating, because most people probably have infections. And the most important thing to do at that point is there's a small minority who end up going on to cancer. It's the vast minority. And now you want to be doing more of your screening, either pap smears or anal pap smears if appropriate. Those are a little more complicated, to see if you have evidence of early cancer. The common, I want to get back to the question here. The common, so there are vaccinations up to the age of 26. There's a lot of discussion because of the oral pharyngeal cancer that's associated with HPV. Should we be doing more with adults? But right now, the evidence isn't there to recommend broad-based vaccination over the age of 26. And the symptoms of HPV, there's 140 different types of this virus. Like you can get little warts on your knees. Those are caused by HPV. But HPV that we're concerned about are the types that either cause genital warts, which are gross in the genital area, and those can be treated with liquid nitrogen, some topical agents or whatever. And we've actually seen a dramatic reduction in warts in young people once HPV vaccine became available, and the vaccine works against warts. And then the other symptoms are really related to the cancers that they cause, of the cervix, the vagina, the penis, the anus. So generally most people, don't present with symptoms. You usually identify HPV if you need to be screened for it through testing and pap smear screening. So hopefully that answers your question. And I encourage, if you're a parent, to make sure that your kids get vaccinated. It's a very safe vaccine. I know Dr. O'Hara ran with your patients. More to add?
Well, and just that, things to also consider would also include making sure that you lead a healthy lifestyle. Like if you were to be infected with HPV, leading a healthier lifestyle, so not engaging in a lot of alcohol drinking, a lot of smoking or any smoking, eating plenty of fruits and vegetables, exercising, those things have been shown to actually be beneficial as well. If you actually contract, and as Dr. Bolan mentioned, the majority of people clear the virus, so you could have a pap smear and it could show that you've, been infected, and then you get another pap smear and another, and then it never shows up again. And lifestyle habits can play a significant role in that.
And also just in general, stress is not good for viral infections. And I know that right now we're living in very stressful times. So, pay attention to your mental health and get care, because that can aggravate. And smoking is a really big one. I forgot to, that was a great point. It's been highly associated with HPV and cancer.
Okay, so there's one other question. It says, Dr. Bolan, it is very nice to see, as a former high school health education teacher that also taught sex education, I saw the urgent need for education about STIs. My question is there any collaboration and communication between your office and public education school systems and their health educators?
Yes, so Lily, great to see you too indirectly. So we have a special division at CDC called the Division of Adolescent and Sexual Health, and they actually support funding departments of education to improve, the health of youth in schools. And they obviously because of where our society is going, are, you know, working not only in the arena, because all these things are syndemics, they're all intersection, you know, so they work in the area of sexual health, they work in the area of bullying. They've actually done some really good work on predictors of connectedness for kids that are associated with resiliency. Unfortunately, like all of public health, their money doesn't go very far, and they used to fund all state health departments of Department of Education to have attention paid to the quote sex ed curriculum, because a lot of curriculums are not medically accurate in some places. So I'd encourage you to go on their website, and certainly you can email me and I can connect you. They're doing some really, really great work. I will say though, because youth is a focus of a lot of our STD programs at the local level, state and local level, there are a lot of collaboratives with STD prevention programs, HIV prevention programs, and the Department of Ed to be working in the schools and providing education in the schools and linking youth to care where they feel safe that they can get their services addressed. So they also try to make the connection to the school-based health centers and other youth serving agencies in the area for kids, because sometimes kids also don't feel comfortable talking to their parents. They're worried about confidentiality, and they want to be in a safe space and talk to an adult that they feel comfortable with.
Dr. Bolan, that last statement you made is very important for the work that we do at the National Bioethics Center, because we work with the bridge builders, that is the high school and middle school students, and we pair them with our bioethics honor students as well as our colleagues in the National Bioethics Center. And we know that we have a responsibility just as humans to be there for these students. Like tomorrow's session for 1 to 3, we will have a therapist, Sunny Etienne, who presented last year, to talk to these young people. And of course, you know that Dr. Choo Saunders and has done this in the past, and they open up and they share. And given our title of vulnerability, each year we see exactly how vulnerable these kids are. And the kinds of things you just said, 12, 13 years old, engaging in various kind of sexual practices. And there's maybe limited guidance. Many of them might not even go to church, so we can't reach them that way. So I'm concerned then when we do our bridge builders, I'm concerned about, in part, how to train our honors students and those in the center to make sure that we're in compliance with the kinds of legal standards to protect both sides. I worked for the Boy Scouts for years, for 4 years before I got out of it, and from 1990 to 1994, and we were very, very big on making sure there was never an adult alone with a child. And you see how you see that Boy Scouts have still slip through the cracks, right? But even in the church, in the Catholic Church and others, some things slip through the crack. So the question is, how do we train and protect both the young people and those adults working with them to ensure that the vulnerability on both sides are not compromised to such a degree that we put ourselves in a liable situation?
Yeah. So that's an outstanding question and a complicated question. I would also say that every state has different laws. So it depends on the state you're working in terms of emancipated youth and what confidentiality protections they are given without parental consent. So it is incredibly complicated. And there are many more people involved in this than I have been recently. And I really would encourage you to look for youth serving agencies. There's a lot of national organizations. They have established curriculum. They've got experience with this. They certainly, health departments vary. I'd encourage, you to always connect with your adolescent, if they have an adolescent program in the health department or maternal and child health, these sort of fall under Title V funds, as well as the STD program, to see what they're doing about it. I will say at UAB, they've got some new leadership there. They're one of our STD HIV prevention training centers, and have really national expert clinicians that you could contact. And I know Jeannie Marazzo has been wanting to get in touch with Dr. Rubin. She's the new head of the infectious disease program. I think COVID has sidetracked that a little bit. So I think there's a lot of, this is where you really got to get your community people together, with ethicists, with lawyers, and come to consensus on what's best for your mentors and your mentees. I think it's clearly needed, and there may be some best practices out there with, what DASH is funding at the local county health department level. Because it's really important work, and boy, when you've got good mentors, it can change the life of a 12-year-old when they don't have any other, support, in their lives at that time of their adolescent development. It's really critical. So I can maybe send you some stuff from what I can find out from DASH, because I think the liability, unfortunately, we have to deal with liability and everything these days, but that should not be your barrier. You really need to move forward with these kinds of programs.
Thank you very much, Dr. Bolin. First, we want to thank you, Ms. Autumn Brownfield, for being such a thoughtful presenter with our presenters. Thank you very much. We thank you. You are one of our heroes in the honors program, and she's one of those who works with the bridge builders. Dr. Gail Bolan and Dr. Heather O'Hara Rand, please now take just a minute or so to give your closing remarks, whatever you would like to say, before we take a short break before our next presentation.
Well, I can quickly say that we need the young leadership, at your institution to get involved. Some of us are getting older. I won't mention who on this call or Zoom. And, we got to start building the next leaders, to carry the torch. And I think that there is, even though you don't hear about HIV in general with STDs, nobody even heard about STDs. We never had the AIDS, social media activities. So I think it's a time to really engage. I encourage all of you. We have, fellowships, student fellowships at CDC. Dr. Rubin's got a lot going on with fellowships. And I really, I think that this is a field that needs a lot of thinking and smart people thinking about these vulnerabilities, the ethical issues, and help us find a path forward that is for what we need to do to improve the health of our nation. Dr. Hodge, you've got yourself muted.
Yes, Dr. Bolin. A question just came through and quickly, and that is by Kayla Lloyd. How do we find out about these scholarships?
So I've got Joe Valentine, I see, has been contributing to the conversation, and she has been, leading. She leads me. She tells me what to do. She's my boss. She knows all the fellowships at CDC, and we'll get you a list so that you can get it out to the participants, or even post it on a website somewhere. I know some, but I know I'll miss a few, so I don't want to shortchange any of the good opportunities at CDC. And I also would say, I started my career, well, first I started as a lab tech at NIH. Then I worked at a local health department. That was my first job after I trained in public health. And I, to this day, didn't know what I was doing, but I don't regret it for a second. So I also encourage students to reach out to local health departments and state health departments. They are desperate for staff, and encourage, those opportunities to open those doors as well. I also believe that academic partnerships with public health and health departments is also really critical each has something to bring to the table. And I think it's overall good for students to have an experience in academic institutions, to go out and have practicums in communities with people, not just sitting at a computer and analyzing data and writing, some journal article. I think that real life experience is critical in public health.
Dr. Bolan, before Dr. O'Hara Rand goes, I'd like to say, and this goes for Autumn and the rest of them, that each year Dr. Bolan would present to the nursing students and the bioethics honor students about careers in the field. And so she's a mentor to you. So please, and Dr. Bolan, I'm sure you don't mind me saying this, please, Autumn, make sure you connect with Dr. Bolan. She is the kind of person who will really give you wonderful advice for your career, because you're moving a high-powered way. What made me think of that, Dr. Bolan, Dr. O'Hara Rand, is one of the person who will be presenting next, a student moderator for next, is a young lady by the name of Sierra Cross. And she texted me and she said that Dr. O'Hara Rand is from her hometown. And she said she wants to be able to connect with you. So I will make sure that the two of you get connected, because those kinds of mentorships are, as you know, immeasurable. I would not be who I am today if it wasn't for somebody who discovered my mind and said, David, you can do this. So those are very important. So Dr. O'Hara Rand, you could go next. Rand, you could go next.
Thank you. And I'm always happy to take on mentees and try to offer whatever I can to help the next generation come up and figure out their way as well. But as far as, so please share my contact information with them. Although I probably want to give you my personal information since I'm transitioning and we don't want to lose that potential connection. I would just say that taking care of your own health is extremely important. You may not realize it now, but as you get older and you want to do things and you want to go places and you want to be, you say, you're always told, reach for the stars. Well, it starts now. And if you can make the smart choices, as Dr. Bolan has tried to, say that if we're leaning more towards our smart choices and not so much towards the things that can destroy us, then you're well on your path. But if you are making those decisions, to do things that may be less likely to allow you to lead a healthy lifestyle, you're running the risk of doing real harm to yourselves as you move on. And some of those harms can include not being able to have a child if you so desire, as well as just not even being able to lead a life that you would want to lead when you get older. So it starts now, and I get it. I went to TU, I got it, I know. I went to Tuskegee. I remember being there. I remember doing things that, well, good, this is going on Facebook, but my parents don't ever need to know about. But, I'm thankful that I had the mentors that I had the support system that I had to ultimately make healthier choices, as opposed to those things that would not be considered healthy or that would have harmed me for the long term. So, my advice is, and this goes definitely, this is definitely something, to really consider. TU is not that big. So you can pretty much be guaranteed that if you're engaging in sexual activity with one person, you're probably engaging in sexual activity with about 10 other people, because of the size, the small size and whatnot. So be careful, wrap it up, be sure about who you're having sexual relations with and how you're having those sexual relations, and really start to have these open and honest conversations, because it is absolutely necessary. It's something that you don't want to start to have to engage in later in life. You want to try and start now.
Thank you very much, both of you, for this wonderful presentation. I have a couple really quick things to say before we move on. One of the things that we didn't get to talk about a whole lot, but which is not necessarily part of the context, we mentioned it yesterday, is the sexual violence that takes place, the rape that takes place and those kind of things, which are, and the date rapes and the shame that a young lady might feel as a result, or a young man might feel, as I tell you the truth, as a result, and therefore that shame pushes them to not report, and in not reporting, not to get the checkups that they need to make sure they have not contracted something. So those are some important concerns to mention. And as to the last point that you were talking about, Dr. O'Hara ran about take care of yourself now, I think I ought to tell you that I have a bruise right here on my arm because back in the day when I went to dunk the basketball, I would hit my arm right here. I had a little bruise because I used to live above the rim. Now I can't touch the net. As a matter of fact, I wave at the net. I give it my best. I get about 1.5 inches off the ground. And that's bothersome because I've gained 100 pounds of fluffiness. And it never occurred to me, Dr. O'Hara, man, it never occurred to me that I would be one day like the guys I saw who couldn't touch the net. So that's just a metaphor for the rest of us that we need to be to do what we need to do now so that later on in life we can be where we need to be. Because I really thought I had a chance to be with Miami Heat. Now I can't even walk through the door at Miami Heat. All right. Thank you so thank you so much, Dr. O'Hara. Thank you so much for Dr. Bolin. We have Dr. Warren. Do you have anything to say before these wonderful presenters leave? And then we will segue into our next session.
Again, this was an exciting and enthusiastic interchange. I kept texting Dr. O'Hara Rand, and I was getting the wrong text and sending them everywhere. So I wanted to say to everybody that I am so pleased and proud that you are a TU alum and a Meharry alum, and we're going to keep you connected. And with Dr. Bolin, you are really giving us new space and place at CDC. I can't thank you enough. And again, what Dr. Hodge, smooth as it is, you'll get there. You'll get there. Just keep on working. This has been, again, an exciting session, and we look forward to staying in touch.